to reframe this as a syndrome because it is a multifaceted, what we call in medicine, a heterogeneous condition, which means that there are multiple different components involved. And these lesions respond to estrogen. There is this sort of misnomer that it's an estrogen dominant condition. So they respond to estrogen. So every time a woman goes through a menstrual cycle where estrogen builds and builds, then that will sort of drive, if you like, those lesions to proliferate and to bleed alongside of the menstrual cycle.
Welcome to Beyond the Pain, the podcast that explores what it really takes to break free from chronic pain and reclaim your life. I'm your host, Leigh Brandon, and someone who's spent over 2 decades helping people get to the root cause of pain that no one else could explain. Whether you're dealing with long-term back issues, joint pain, nerve discomfort, or mysterious symptoms that just won't go away, this show is here to help you go deeper. Because beyond the pain, there's clarity, strength, and power waiting for you. Each week, we'll uncover the physical, emotional, biochemical, and energetic causes of pain and how to transform them. Let's dive deep into this week's episode. This week on Beyond the Pain, I'm joined by Tanya Borowski for an eye-opening conversation about the complexities of women's health, specifically chronic pelvic pain and endometriosis. We explore why these conditions are so often misunderstood and how an integrative approach can make all the difference. Tanya shares valuable insights on the role of environmental factors, the importance of understanding hormonal health, and practical steps women can take to better manage their symptoms and reclaim their quality of life. If you or someone you care about has struggled with pelvic pain or endometriosis, you won't want to miss this one. Tanya, welcome to the podcast. It's great to have you here.
You're welcome. It's fantastic to be here. We had a little bit of a issue with microphones to start with, but the listener doesn't need to worry about that. So
yeah, I wasn't gonna mention that bit, but don't worry, it's all good.
Well, it's all good to make it real.
So I'm really looking forward to diving in and talking to you today, specifically about your work around women's health and particularly persistent pelvic pain, which I know is a topic that so many struggle with, often silently. So to kick things off, could you share a little bit about your background, what led you to work in women's health, and what sparked your interest in helping those with persistent pelvic pain?
Amazing. Yes, I'd be delighted to. So my first modality was in this world was nutritional therapy. So I trained in nutritional therapy, actually started in Australia. I was living in Australia for a decade, and so trained as a naturopath in Australia, and then moved back to the UK and started to work in clinical practice, and probably like most individuals realized that first modality really just touched the surface, if you like, and that very quickly recognized that I had an absolute passion for wanting to connect the dots and to know more, and also recognizing this was going to be a lifelong learning, and that coincided with the same time that the Institute of Functional Medicine was starting to become more well-known and more recognised, or the term functional medicine was becoming more recognised in the UK. And they brought over to London their inaugural sort of initial training module. And it was a 5-day sort of foundational course in functional medicine. And I was on the edge of my seat, Leigh. it was 5 days. I had to scrape together the money to afford the course itself. But I was on the edge of my seat and just knew from that, really within that first lecture, that one day, I wanted to be that person that was up on the stage, and I do come from a sales background, and B, just that this was absolutely that I'd found my calling, and that wasn't specifically about women's health or hormones or endocrinology, but it was just the thought process of interconnected medicine, of knowing that there is always a cause and effect, and that so many conditions and syndromes are multifaceted. So that then I then embarked on training and going through their qualification, which took another 2 years. And at that point, that involved traveling back and forth to the States because you couldn't do remote training at that point. But for me, that was ideal, because I always find that learning in a room and being surrounded by your tribe you just absorb more. And that then really developed my interest in working more specifically in women's health, because I began to recognize and see that women's health was so underserved, both in the areas of research, and it just seemed that there was such a linear approach to conditions that are associated with women's health, and everything seemed to be put at the door of it's a hormone imbalance. And then really the solution was pretty much always, well, let's stop those hormones and let's put women on the pill until they reach the age of menopause, and then the solution is, well, okay, now we'll replace them. And it just seemed to me just so illogical that this was just it was approaching so many such conditions with such a blunt instrument. And that's sort of a very simplistic way of explaining it. But within that, I fell in love with understanding biochemistry and the connections of that biochemistry, and how we always talk about, or the term hormone imbalance is used so flippantly, actually, and it's so much more than that. It's about the ebb and flow that our hormones play that interact with our immune system and our nervous system. So we now talk about the neuroendocrine immunosystem, and that really far better encompasses so many different conditions that I work with in women's health, be that endometriosis, be that PCOS, PMS, PMDD. All of these types of conditions involve multi-systems, and it just continues to fascinate me. And it is now becoming there is much more awareness, but we still have such a long way to go, and bridging that gap between the medical system and complementary or integrative medicine. And my hope and my dream is that increasingly that bridge becomes much easier to walk across, and to facilitate that, there is a far better working understanding, a relationship between medical doctors and this communication with other types of healthcare practitioners that can be incredibly supportive, because it takes a village. And so many of these conditions that we're focusing in on, talking really about chronic pelvic pain and endo today, but they require such a intricate group of people to be able to support that one woman, because there's so much that's involved. And that's really what I continue to do and love doing, and never stop wanting to go to a conference or flying off somewhere to learn about something that's around women's health. So that's sort of where I am. So I've been in practice for coming up to 20 years. Yeah, I love what I do.
It comes across like, your passion is clear, from just hearing you speak today. Obviously, I've heard you speak several times before, but what it really feels like to me is I'm speaking to a fellow nerd. You love to learn. You can't get enough of more information, which is exactly what I'm like as well. I just can't stop learning new stuff and wanting to use that information to help people. Not necessarily, female pelvic pain, although there are times when I have helped women with those kind of problems. But for me, any kind of pain. But
Yes.
but yeah, I guess it's great to be talking to a fellow nerd and someone that shares a similar passion for learning and helping people with that knowledge. Yeah,
And
something.
I take that as a compliment. And I think that this can occur in any walk of life and modality. But when we become, and I will use this word, when we become arrogant enough to think that we know everything, and this can, as I said, this can be applied to anything, then really, then we may as well walk away, because I believe that we've always got to be open to relearn what we think we know, because science moves and science changes, and the life and also the environment in which we immerse ourselves in is infinitely, and that environment is key to how that interacts with all of the systems that we want to learn in a textbook fashion. But unless we actually respect how that environment changes, we're never going to be able to really truly support our clients. So I think always be open, and I use the word lens a lot, and this is very true with endometriosis and chronic pelvic pain. And you can sort of bear with me, I just always have this image in my head of a kaleidoscope, one of those those kids kaleidoscope. You and I are a similar age, that you sort of look down and you just move the end of that kaleidoscope just slightly, and the picture changes and the colors change and the depths of the colors change, and that presents to me in women's health, just that slight change creates an opportunity to heal, because you're changing the environment, or you're seeing a touch point that we have the power to be able to work with, and that is truly remarkable. And that's very different from taking this, run a set of bloods, and don't get me wrong, there is absolutely a place to do that, and to be able to rule out serious pathology when you're looking for key markers. But for so much of what forms into the realm of what you and I work with, is that we can use gold standard markers from a blood test to be able to help to rule in and rule out certain situations. For example, is there anemia present? And we can support that. But we are the depth of knowledge that we can gain from really spending time with our clients and our patients and hearing their story to actually map their case is invariably, that is where the gold is, to be able to make those interventions, to be able to apply those interventions.
Yeah, when you were speaking a little bit earlier, the thing that came to my mind is that there's complexity, but there's also simplicity. And what I mean by that is the human form is so complex, right? We've got so many different systems, as you were saying, they all interact. So, in the situation, that you stated, if a woman has a hormonal imbalance, in inverted commas, okay, let's take birth control. And then when you get to menopause, just take some more pharmaceutical to supposedly balance them, without looking at all the potential causes that could have caused the imbalance in the first place. But then when it comes to the solution, actually, oftentimes it is relatively simple. If you look at, as you were alluding to, you've got to look at someone's environment. God knows what they're spraying in the sky. We kind of got an idea of what's in our water supply. We've got an idea of what's in the food supply. We've got an idea of what's in all the, stuff that we clean ourselves with, clean our houses with, the stuff that outgasses in our cars and our sofas and all that kind of stuff. But yet, the solution is, just take a pill. That's going to solve all of those other issues that have caused your problem in the first place, right? But actually cleaning up your lifestyle is actually relatively simple. There are obviously, where the complexity of that comes in is behavior, right? That's the challenge, because people don't like changing their behaviors. They like their habits. They like their comfort zone. And for most people, to change means going outside their comfort zone.
Yep.
Right. And that's quite scary for a lot of people. And it's not a comfortable thing for them to do. And something I always try and remind people of is that you generally don't achieve anything amazing unless you go outside that comfort zone. Right.
Yeah.
But, and to put it another way, the closer we live in alignment with nature, the more likely our bodily systems are going to be in balance. And the more we move away from nature, the more likely our bodily systems are going to be so-called out of balance, because it's trying to compensate.
Yeah, and that the beauty of that is the simplicity of it. But actually doing that is for a lot of people is very difficult. And I think that it's not anybody's fault. And Lara Briden actually talks about this in her recent book, Metabolic Reset, is that we are in a complete evolutionary mismatch, and that it's not anybody's fault, but we have, and I think COVID really woke everybody up to that, because suddenly overnight we were having to step off the proverbial treadmill, and actually, and I think then it began to people then really began to question, well, hang on a minute, why am I getting up at 5 a.m. and getting on it and spending £500 on a season ticket to go into London and never see my kids? And okay, yeah, I've got a nice car in the drive and I've got a nice house, but actually, does this really truly make me happy? And actually, what is the point? And I really do, yeah, certainly within my circle, I really noticed that there was a definite step change in what people recognized, that actually they really could, how they wanted to truly live. And I think that that's quite interesting. And certainly women's endocrine system, so their hormonal system, it is more complex. It is more complex than male.
Yeah.
And so therefore that interaction with there is more of a state of flux throughout what is called their reproductive years, because there is a natural ebb and flow of the key ovarian hormones, estrogen and progesterone, and those actually interplay very much with on how we make our neurotransmitters. So it's no surprise that there is a natural change in the way that we feel across the menstrual cycle, because for example, estrogen is a cofactor, is needed as a cofactor to make serotonin, to make dopamine, as an example. But also those hormones are involved in the removal of those neurotransmitters. So whereas just the natural ebb and flow of those hormones across that woman's menstrual cycle will change how driven she is, or whether she feels more insular and she wants to hibernate, or whether she's got more va-va-voom and more drive, dependent on where she is in her menstrual cycle. And so to your point, we've become there is a really important point, and I really feel passionate about this, about we need to go back to the way that we educate our children about.
I was just thinking that.
Our hormones.
But particularly the males.
well, male, yeah, young men and young women around, because the way that it's pitched in our education is about sex education, which of course there is a place, but that's basically all it is. It's about sex education and contraception. There is a place for that, but actually there's no engagement or excitement or thrill or wow factor around. And look at all of the reasons why we produce these hormones for 3 or 4 decades of our life. It's not just about reproduction. It's about bone health. It's about helping to make your neurotransmitters. It's about cardiovascular health. It's about modulating your immune system. And I think that this goes right. I would love to be involved in any way of being able to because the more that we can engage our young people about the power of and truly understanding our body, then of course there becomes an understanding of why, to your point, we want to be as more aligned with our circadian rhythm and nature as possible. But if that information comes in our 40s, by which point we've just spent 2 decades just completely taking that for granted, it's very difficult to change those habits. So, yeah.
Yeah, it's interesting. I mean, this isn't something that we're going to talk about, but again, just thinking about education, and you think if you were teaching teenage boys about the effects of the fluctuations in hormones in females, would that not make a massive difference to their ability to have a good relationship later in life? Right?
Yeah.
Because most people think that women are aliens, right?
Yeah. I mean,
but if they understood the ebb and flow of estrogen and progesterone and what effects that has on a woman, they'd probably be a lot more empathetic rather than complaining about, oh, they're in this mood or that mood or whatever. Well, if your hormones were going up and down like that, you'd probably be in a mood as well, right?
Yeah.
So I think it would just allow for a lot more empathy.
I'd like to think so. And also just, it's true. It's about understanding what is going on in this amazing body that we all inhabit. And we're so used to actually palming that off. There isn't a responsibility, and I'm not for a minute suggesting that it's someone's, when they're in chronic pain, I'm not saying it in any way that's their fault, but actually having a more in-depth understanding of human physiology is incredibly powerful in of itself. Because with understanding comes maybe the desire to change and to try something, and also but if we don't understand something, then we hand everything over, combined with the fact that our healthcare model is, GPs they don't have the time they don't train in all of these different systems to that amount of depth. So a GP can't be expected to know the intricacies of all of these components. So it is from a women's perspective. I mean, I just hear so many horror stories where maybe the wrong type of pill was prescribed, with the wrong type of progestin in it, and when it comes to menopause hormone therapy, whether, again, it's the wrong type of formulation or dose. And it just comes from not having the time to really actually understand the intricacies of it. And there's so much information. So it is, And again, it's about bridging that gap.
Yeah. And that's the complexity, right? But, I always see my role as understand the complexity, but delivering it in a way that's simple. And that's really what, in an ideal world, what GPs would do. But as you say, they haven't had that level of training, sadly. Let's take a short break because Amelia's story is one I think many people need to hear. She came to me with such severe neck pain, she couldn't turn her head. She had to rotate her whole body just to look sideways. Every movement was painful. She was also bloated, exhausted, and terrified that surgery was her only option. We built a holistic plan that addressed her neck and her gut. The result? Amelia got full range of motion back, her digestion improved, her energy soared, and she finally felt like herself again. If your pain feels overwhelming and you don't know where to turn, grab my free chronic pain breakthrough blueprint at www.bodycheck.co.uk/free pain guide. It's designed to help you get to the root of what's really going on. So moving on. So one of the things that, or the main thing we're going to talk about today is endometriosis. For the audience, can you give an overview of actually, what it is, what are the typical signs and symptoms that, someone might experience with endometriosis?
Yes, absolutely. So endometriosis is it's a complex condition. I'm going to try and not use the word disease because there is a movement within both the medical community and within the more sort of the supporting communities to reframe this as a syndrome, because it is a multifaceted, what we call in medicine, a heterogeneous condition, which means that there are multiple different components involved. But it's characterized by the presence of endometrial glands, and the endometrial, so the lining of the uterus, that actually take up residency outside the uterus. And this tissue can be found like in the pelvis, in the ovaries, in the fallopian tubes, in peritoneal surfaces, in the bowel and bladder, and sometimes even very distant organs like the sinuses, amazingly. And these lesions respond to estrogen. There is this sort of misnomer that it's an estrogen dominant condition. So they respond to estrogen. So every time a woman goes through a menstrual cycle where estrogen builds and builds, then that will sort of drive, if you like, those lesions to proliferate and to bleed alongside of the menstrual cycle. So with that, over time, then there can be fibrotic tissue that builds up, and that's what causes basically the pain. So it is, and we'll kind of come on to what other there are. So that's basically what endometriosis is, and it is very sadly, it is very poorly diagnosed. The route to diagnosis can be, and in this country, in the UK, can be up to 10 years, which is woeful. And so many, in fact, Endometriosis UK have published last year a really fantastic document, which is very easy to read, and I encourage anyone to read just about, and they interviewed thousands and thousands of women across sort of reproductive age, and the stories are tragic of the dismissal of it's just period pain, basically put up and shut up, and it makes for some pretty sad reading. So symptoms, so basically sort of symptoms are quite broad, but it is the symptoms to be aware of are severe period pain. Period pain, I just want to caution the word, I'm going to use the word normal, but please, listener, please just bear with me to the end of the sentence, is that so a level of cramping and releasing that endometrial lining because of how much it is thickened across the menstrual cycle, and the process of doing that activates part of the immune system and the release of what are called cytokines and prostaglandins and mast cells that can and does cause a level of cramping, and so therefore can cause and does cause a level of pain. But it should be, and that is normal, but that what is normal is that pain that can maybe begin to occur 24 hours before the first day of the bleed and continues maybe for 2 to 3, maybe 2 days of the bleed, that is relieved by taking ibuprofen or other maybe more natural alternatives of pain medication and applying heat, etc. So that is basically what we call primary dysmenorrhea. So pain, that is sort of when it moves into what is called secondary dysmenorrhea. So dysmenorrhea is the medical term for painful periods. Then that endometriosis is the most common cause or syndrome that causes that. And what happens is that pain will invariably happen pretty much constantly across the menstrual cycle. It may become more exacerbated when she's menstruating, but it doesn't relieve. And over each decade and year, it gets increasingly worse. Whereas with what we call primary dysmenorrhea, then generally that will dissipate. And the reason that with endometriosis it gets worse is because as going back to what I said at the beginning, we've got these lesions that are that have taken up residency, if you like, in tissue where it shouldn't be. And every time that woman is going through a menstrual cycle and the building of that estrogen, those lesions are becoming more and more prolonged and inflamed and agitated. So it becomes a vicious cycle. So and then you have sort of very heavy periods. There is fatigue. That can be because they're having heavier periods. They may be becoming anemic. I see that quite commonly. But it might be for other reasons. Of course, low mood and depression, because if you're in that much pain 3 weeks out of 4, then that is going to be, that is going to impact your nervous system, and of course because it becomes very debilitating. And these women, because of the heavy bleeding, I mean, they're going through a sanitary pad in half an hour.
Wow.
And so it becomes, it doesn't matter what age the woman, but that becomes incredibly debilitating in terms of being able to socialize, let alone the pain. It just means it's very limiting for how they can interact with the world, because they're just fearful of bleeding through their clothes, and it's very debilitating. So those are the main, and then of course there is infertility. So, but it is not quite often the delivery of a diagnosis with endometriosis has historically been very brutally delivered as well. And actually, when I was in Australia, I was fortunate enough to be in Australia and do some presentations at the back end of last year, and we were talking about this, and a young girl came up to me afterwards and said, she was 22, and she said, I've just been diagnosed with endometriosis, and I've been told I'm infertile, I'll never be able to have children. And that is just, that's incorrect, and it's just a brutal diagnosis and delivery to give a young woman, because there are so many avenues to be able to pursue. But that's a very long-winded way of me hopefully answering your question of what it is and what are the signs and symptoms.
Yeah, no, that was great. One of the questions I've got in my mind, and I don't know if there is an answer to this, but I know there have been lots of studies done on, let's call them native tribal people. And quite often they don't have, like, for instance, it's something that now I've looked into in detail. They don't suffer from acne at all, right? As one example, I know those studies have been done. Do you know if there's been any studies done with native people living in their natural environment? First of all, do you know if there's been that study? But also, if there is those studies, do they also experience pain when they're menstruating?
It's a really great question. The short answer is I don't know if there is a study, but I do know that. But I'm definitely going to look into that now. But the correlation that I would draw is that I know that there are studies that are done on the Hasda tribe and other indigenous societies around the experience that these women have around in perimenopause and menopause, and they do not experience feelings of loss or brain fog or fatigue, and it is a transition in life that is part of a step change. And therefore, and I think that this comes back to, if we're talking about endometriosis and pain there, and heavy bleeding as an example, and as part of that, we know that a significant component to this is a dysregulated immune system. And we know that therefore, okay, so what then dysregulates an immune system are environmental triggers that overwhelm the immune system to tip into a feed-forward aberrant response. So the more inflammatory side, so by that I mean, and that can be, there are definitely studies done that persistent pollutants, dioxins, all of these environmental chemicals that are far more abundant that are ubiquitous in our water supply, and in our environment, absolutely upregulates the immune system. And when we upregulate the immune system, and then then that actually has a feed forward cycle to many different connections. But one is it upregulates something called VEGF. And VEGF then actually causes more angiogenesis. So and that actually creates more vessels to feed these endometriotic lesions. So you can very easily plot and map how this can actually take place. So I could definitely see a route in either way of that. But this dysregulated immune system is a central piece to endometriosis, and that the immune system has, in women that we've studied, that they are not able to clear. There are certain particular subset of cells called macrophages, and they kind of belong to two different families. And there is they've shown that actually these macrophages have a less ability to be able to clear the natural retrograde menstruation that occurs of and of fibrotic tissue that happens each month, because the immune system is dysregulated, and that is one component that we know to be the case.
Yeah, it would be great to see if there was a study, wouldn't there?
I will get back to you on that,
because that would kind of underline how much of a role, I guess, our current environment plays in that condition, as we know it does in lots of other conditions. So yeah, that would be interesting. So that's what it is, or at least that's what the symptomology is.
Yeah.
What do medical doctors and researchers currently believe cause endometriosis? Like, do they have a clear explanation of why or how it develops? Just a quick pause to share one of the most inspiring comebacks I've seen. Michelle was a top-ranked swimmer whose shoulder pain was so bad, even after surgery, she was told to retire. She was heartbroken, but she had one goal left: win gold at the European Championships. We worked together to build her strength, correct her posture, and optimize her recovery. Not only did she win gold, but she also set a European record and kept competing pain-free. If someone's told you to give up on your goals because of pain, don't accept that as your story. Download my free chronic pain breakthrough blueprint at www.bodycheck.co.uk/free pain guide, and let's write a new chapter together.
No, so in terms of the multifactorial components to it are there are certain genes that are that are at play, and there is a hormonally driven component, i.e. it is estrogen driven, and in many women there is a progesterone resistance component as well. There is a significant inflammatory process, so there is a sort of an inflammatory milieu of cytokines that then drives angiogenesis, which feeds the lesions. There is a dysregulated immune component where there's a degree of subset of, if you like, defunct natural killer cells. And then there is also a dysbiotic component, which is both from the gut, but also more interestingly, and this is very, very recent, around endometrial microbiome component to that as well. So it is, in all the sort of most recent papers, is that it involves all of those components, and actually the integrative world has a far broader toolkit of intervention to be able to support that than the medical, because the medical approach, in my experience, is either surgery, which removal of the lesions, which has its place for some women, but not all by any stretch of the imagination, or hormone therapy. So, i.e. turning off, and generally that is using, so to prevent the heavy bleeding, so prescribing either an IUD, or in some severe cases, even switching the whole system off completely. But their treatment, that's really that is the focus of gynecology, in my experience, of the treatment. Whereas we, through our lens, we have a much broader kit bag to be able to support still the hormonal component, because we can also support the clearance of estrogen and the biotransformation of estrogen. And in short, we can run nutrigenomic panels to look at how predisposed an individual is to. They might be genetically predisposed to actually synthesize more estrogen, or they don't have an ability to produce progesterone as robustly, for example. And of course, we have a far broader toolkit to be able to modulate the immune system and provide support with reducing inflammatory processes, and of course the environmental factors. So that is a big piece. So counseling and working with clients around how to remove certain environmental components from their environment. And in your world, the hypoxia is also a really big issue with endometriosis. And chronic pelvic pain. That becomes this sort of stagnation, if you like. So there is this fear around movement and breathing. And of course, the more in pain we are, the more fearful we are. What do? We stop breathing. We don't breathe properly. We shallow breathe, because that's what we do when we're panicked. So the working, I very often, and that is the beauty of a multidisciplined approach, and sort of working with a very in tune and qualified body worker that can actually show a woman how to move appropriately through her menstrual cycle and be able to oxygenate and be able to move blood is very, very important, is very important, and to learn how to breathe properly.
Yeah, I mean, again, if you think about breathing properly, you know, if you inhale and you use your diaphragm, which is how you should inhale,
yeah,
what does it do? It expands the abdomen.
Yeah.
Right. So I can imagine most women, they're in pain. They want to tighten that area, right? Because they, you know, so there's almost a double-edged sword there, really. But, you know, not only would that improve oxygen intake, but it would also make them more parasympathetic as well, which is going to help with pain.
Definitely.
Right? Yeah. But the other thing you were talking about there as well, and what I was thinking was, okay, so doctors are prescribing hormone medications or surgery or, you know, whatever else, IUDs, etc. What about a discussion on endocrine disruptors from their food supply or from their environment, right? Oh no, forget all that. We've got the solution. Let's just take a pill, you know.
This is why, yeah. I mean, this is not about, and I'm sure it's not about slamming GPs. I mean, it's just like, but they are not. That's kind of. I'm sure that's what's in the NICE guidelines, is that's what's prescribed. So it is. But it is just one component, and absolutely there is a place for being able to support that woman to stem the heavy bleeding while you can work on all of the other components. But it is just one. It is just one component.
Yeah.
So yeah.
Yeah, sorry, I smiled when you said NICE guidelines. I've got a bit of an issue with NICE guidelines, but that's a whole nother episode.
Yeah.
I don't want to go into it, but if anyone wants to understand what I'm talking about, just research NG163. But I don't want to go into that now, because that's a whole another topic I've already discussed many times anyway. But
okay, I'm not looking at it.
So you've mentioned a little bit about, you know, how endometriosis can be treated in the medical system. So generally, as you're saying, hormone treatment, surgery, etc., etc. But how is it diagnosed? And I guess, in your opinion, what have you seen in terms of the effectiveness of, let's call it, medical treatments for endometriosis?
I mean, I have seen, I've got family members who have been purely down the medical route, and there is a level of success. But the bottom line is, there have been multiple interventions and laparoscopies, but really the only true resolution came once they graduated into menopause. So, you know, how successful is that? So it's quite interesting, because these lesions, so you can have a vaginal ultrasound, which is less invasive, but that doesn't it doesn't pick up all the lesions at all. So there is you can have a laparoscopy, which is also used as surgery as well. So that can be used to diagnose. And then there is a grading of the lesions. So there is from grade 1 to 4. So 4 is the most severe, so very deep lesions, deep infiltrating lesions. But what's incredibly interesting is, so unlike where cancer, where we talk about grade 4 is the top, and that is very serious, having in endometriosis with the lesions, having a more advanced stage of endometriosis does not always, in fact, it does not always, and in my experience, actually very frequently, mean that you have more severe symptoms or pain. And I have had clients who have had interventions and have been sort of told, oh, did you know that you've got endometriosis? And actually, and they don't experience any symptoms whatsoever. And then, so once you've got this diagnosis, there is definitely an element that then one can become the diagnosis, which is, there is a fear factor around that. But coming back to the point of, even if you found to have a grade 4 deep infiltrating lesions, some women with stage 4 endo have very few symptoms. So really it is about supporting the symptoms of that woman, supporting their heavy flow, supporting their pain, supporting and looking at how we can ensure that they're across their menstrual cycle, that they are clearing their estrogen effectively, as an example, that we're modulating their immune system. And we're absolutely looking at all of the environmental components as well. But that's in the medical model, that's how it's diagnosed. So we feel, and in fact it was in the BMJ, that we are far more consistently like to characterize the symptoms and treat this and support or treat the symptoms, and refer to this as a syndrome rather than a disease.
Yeah, you mentioned laparoscopy. For the audience, could you just explain what that is, in case anyone doesn't know what that is?
So it's a surgical procedure where they use just a small sort of fiber optic instrument that's inserted through the abdominal wall, and it facilitates allowing to be able to view sort of organs in the abdomen, and so be able to view the lesions, but also this is actually used for surgery as well, so for eradication of the lesions. So that's why it can be used as either an operation to make small incisions, or it's a diagnostic instrument as well. But the waiting time for this commonly is quite long, and unless women go privately, and of course not every woman can afford to do that privately.
And do you know what the success rate is for surgery?
Yeah, it's well, I think probably the proof in the pudding is that once you get on that train, women very, very, very rarely, if not at all, just have one intervention. They have to go back for multiple surgeries and removal. So that the old age adage, if you have to keep going back to do something 4 or 5 times, something ain't working, or we're not addressing the pathophysiology of, like, the angiogenesis, etc., that's driving that, or the hormone dysregulation, etc. just by removing them, it's not actually preventing the development of the lesions. So yes, there is a success rate for a year, 18 months, but it's not uncommon for women to have repeated interventions from 5 up to I mean, I had, in fact, Dr. Peter Wright, I've heard say, who's a leading gynecologist in Australia, who's sort of had 15 interventions. It's like, again, if you're having to do that many times, is that successful?
Yeah, because what I've heard, and certainly reading Dr. Wright's book, it seems like, yes, the endometriosis has been removed,
Yeah.
but it doesn't necessarily equal the pain going away.
No. And this, we see the same in, so in women who have, very sadly, women who have hysterectomies, and they resort to that in conditions like PMDD, which is, for those of you who are not, PMDD is a far more intense neurological relation to PMS. So it is another incredibly debilitating condition where these women experience devastating mood changes across their menstrual cycle, with only sort of 4 or 5 days relief. And the same is true with women who have chronic pelvic pain, when they sometimes revert to having a total hysterectomy, thinking, okay, I'm just going to switch everything off. There is this memory pattern, and there is this of the communication between the brain and the ovaries to produce estradiol that we still see happening even either when women enter menopause, and that mechanism no longer operates in such a great, or they've had a hysterectomy. But yes, to your point, that is not a given, because the body kind of has set down learning patterns, is the way that we view it. And this is where the central point of Dr. Peter Wright's work is. The central piece to this is, in an essence, is retraining the nervous system, because those pathways become so embedded of fear and that sort of that parasympathetic drive, which then fuels pain. It becomes so embedded that it's a retraining that actually forms part of the treatment plan. And that is why, again, it's another beautiful part of our integrative kit bag that is so powerful.
Yeah, I guess I get frustrated when I hear, people, they go for help and the solution is, well, let's just cut it out of the body, right? I mean, we know there's something called phantom pain. Someone can have an arm amputated, and they can still feel pain in the hand. The hand's not even there.
Yeah.
Right? And, the amount of times I've had someone come to me with lower back issues, and they've had a discectomy, and they say the pain's actually worse, or it hasn't changed at all, right? And it's because they haven't changed anything else. They haven't looked at, okay, what caused that in the first place? And I just get really frustrated when, oh yeah, you've got this problem, let's just cut it out of the body. I kind of believe the body doesn't make mistakes. The body's responding to its environment.
It is responding to its environment. And we have these sort of tiny, nerve endings and nerve fibers and afferent and efferent nerves that absolutely respond. I mean, just respond to the tiniest change in tissue chemistry and the milieu, that just being a human being and existing, we don't live in a bubble. And so therefore there is this continual stimuli both externally and endogenously, so within the body, that these nerve endings are responding to. And in the area of the pelvis, that we have this in menstruating and cycling women, so right back to the theory of where endometriosis originated from back in, I think it was the 1920s, of the theory of retrograde menstruation, was that meant that this menstrual blood that contains these endometrial cells was flowing backward sort of through the fallopian tubes and into the pelvic cavity. Now, we now know that that actually is a very normal and commonplace situation that happens in pretty much all women, that we all encounter that. But it is this sort of dysregulation of the immune system that has this inability to be able to, that should be able to clear that debris and all of the communication molecules that then activates, because we have a change in tissue chemistry. So immediately there's a change in tissue chemistry. The immune system pops its head up and says, aye, what's this? And we want that to happen. That's what its job is to do, is to become awoken and create a small inflammatory response to be able to have the resolution phase. But
can we talk about the kind of pain people often hide? The kind that affects your gut, your skin, your energy, and your confidence. Sharon, a finance professional, came to me with stomach pain, breakouts, insomnia, and exhaustion. She felt run down, bloated, and stuck in survival mode. With the right testing and a personalised plan, Sharon healed her gut, cleared her skin, started sleeping through the night, and the weight around her middle melted off without even trying. If your body feels like it's giving up on you, don't ignore the signs. Download my chronic pain breakthrough blueprint for free at www.bodycheck.co.uk/free pain guide. You can feel like yourself again.
The answer is not just to have one theory and then say, okay, this is the issue. So we just, okay, if we stop the menstrual flow, then that will solve the problem. Or we cut out the tissue. That we're not dealing with cancer here. We're talking about natural physiology that has become dysregulated, and a number of systems have become dysregulated in the presence of a genetically prone individual. Now, we all have genes and variants that are unique to us. Nobody has a complete clean bill set of health. That's the beauty of being human. But it's what actually overwhelms that genetic predisposition to flip that switch to set the scene of an ongoing aberrant inflammatory response that becomes unrelenting. And I think, again, it comes back to the way that this lack of sort of being in tune with our bodies through, again, no fault of our own, but that's what, if you don't feel well, you go to the doctor, you have a 10-minute appointment, you're given a pill. Well, we chase a diagnosis. Great. Okay, we have a diagnosis. We've got, what's the pill for that? Off you go. Now, in acute care, that's great. But the majority of conditions that is causing our healthcare system to be on its knees is the overwhelming amount of conditions that are, as far as the medical constabulary concerned, are idiopathic. Okay, I can't give you a diagnosis. This is where fibromyalgia, ME, chronic fatigue, they all fall into this net of there isn't a sole cause. So, okay, I'll give you this for the pain. I'll give you that for the constipation. I'll give you that for the diarrhea. And endo is very clear, is the same, is that when you've got that level of inflammation, it's going to impact bowel habits. But you don't, giving something for constipation isn't going to sort the problem.
Yeah. So from your perspective, obviously you use an integrative approach.
Yeah.
And then obviously you've got the medical approach. What would you say are the main differences in the way that you work with someone with pelvic pain and the way that someone's likely to be treated via the medical system?
Okay. So I do work with a number of amazing doctors. I would really
Good to hear.
Yeah. I mean, there are there are, and I really, really truly believe that everybody goes into healthcare to want to do good and to make a difference. I think where the reason that working collaboratively and an integrative approach is so successful is starting off by giving that woman the actual time to be able to be heard. And as we started off this conversation with, sadly, there are too many women that, well, first of all, let's just back up. It takes a lot of courage, especially for a young woman, to go and visit a GP to say, I'm having really heavy bleeding and I'm in pain. That takes a lot of courage, even just to talk about her anatomy in that way. And there can be a whole array, of course, of cultural issues and barriers around that as well. So being able to create an environment where that woman feels safe and can actually be heard without judgment and without clock watching is a really powerful first intervention, because where the beauty of this approach really takes hold is trust and building a therapeutic relationship. And so within that therapeutic relationship is explaining in a way that doesn't instill fear that this is going to be a journey that we're going to do together, that this is a partnership of, I really want to educate and teach you about the different components that are happening within the body so that you understand why I'm asking you to make certain changes, because the accumulation of these changes is what actually shifts the dial and moves the landscape. Or going back to one of my very original analogies, is it's accumulation of those that change the kaleidoscope to be able to change the colors. And that actually is what makes the difference, is that it's drawing these different threads at certain points. And that can be, okay, what can we do? What interventions can we do to help you settle your nervous system? And we talk around sleep, around the importance of being in touch with your circadian rhythm, around the importance of breathing, moving, oxygenating, and of course nutrition from a whole array of different components. But as an example, when somebody is insulin resistant or they've got dysregulated blood sugar issues, that's going to cause, that in of itself exacerbates the immune system, because wherever there is dysregulated blood sugar and a heightened stress response, you're going to get an uptick of inflammatory cytokines that basically messes with blood sugar disposal and regulation. So very quickly then it's about unraveling all of these different threads. And that is that's so different to a linear approach of, okay, well, really all that's in my kit bag is we're going to turn off the hormones and I'm going to give you some pain relief. That is the beauty and the difference. It's a longer, but it's also explaining that this is a longer process. This is not gonna. There are going to be peaks and troughs along the road, and you're just going to have to trust me in the process. But all with a view to relieving your pain. And this is possible, and fertility is possible. It is not a sentence of infertility, but it is, and it is definitely. But the nervous system, if you like, is probably the most pivotal intervention that is central to all of this. Because with a dysregulated nervous system, the center is off balance, and that kaleidoscope is never going to be able to show the depth of what it needs to.
Yeah, that's an interesting point. Just reminded me of something. Someone told me many years ago he had seen a lot of women with endometriosis, and he said in every case they were like a high-flying executive trying to succeed in a so-called man's world. And it's, I thought that was quite an interesting comment, that they were all very, very similar. But that does fit into, a dysregulated nervous system. Whether it's going more esoteric, they're becoming too masculine, they need more feminine energy in their life. I don't know.
Yeah, it's a very interesting. I mean, there's probably a whole 2-hour conversation there, but on a fundamental level, if the immune system if there's just heightened levels of adrenaline and cortisol, then that is going to negatively impact so many components to this web. So, and it's also, I mean, a big link is that inflammatory response of cortisol and adrenaline is going to stimulate VEGF, which is another communication molecule, and VEGF is a proliferative communication molecule, for the want of a better word, that upregulates angiogenesis. So you're feeding more blood vessels into those lesions. So any type of inflammation is just going to keep feeding that angiogenesis. So it's continually about breaking these vicious loops. And the beauty of, let's just use one nutraceutical as an example. And I'm not for a minute saying omega-3 is going to cure endometriosis, but just the beauty of thinking about selecting specific either nutrients or herbs. I'm always thinking about, something that is going to have multiple impacts across the map and the web that I'm working on. And this is how I how I teach. So as an omega-3, as an example, is anti-inflammatory. It will reduce it has impacts on those COX and LOX pathways and reduce those inflammatory mediators. The high amounts of DHA will have neurological and cognitive benefits. It is also going to tame, has a mast cell stabilizing component, so it's preventing the liberation of all of the components and histamine that is inside the mast cells, and therefore helping to reduce the contractions. So there are the beauty of nature when it's thought through, but that is very different than what we're not doing is talking about polygreen pharmacy. It is not just replacing a pill or a medication for a supplement. That is not what this is about.
Yeah. Have you seen, or do you know, are the numbers of women suffering from endometriosis, or you could say pelvic pain, do you know if that's increasing?
Yes, it is increasing because the route to diagnosis is taking so long. So yes, it is increasing, but that's one component. But also because we know that the again coming back to the environmental pollutants plays such a big component to upregulating the immune system or dysregulating the immune system, and switching on that genetic predisposition.
Yeah. I mean, the reason I asked that question was because there has been, as I think you might have been alluding to, an increase in environmental toxins. There was a big one in 2021 that we all know about that's been spoken about a lot, and I've been cancelled for talking about many times. But also, the 5G network, we don't know what effect
Exactly.
that's having on us. How many people use mobile devices near their abdomen, laptops on their lap, mobile phones, tablets on their lap? How much of an effect could that potentially be having? I would suggest could be a huge effect.
Definitely. And in fact, I've just found that the survey that I spoke about, which was done by Endometriosis UK, and in the UK, so this was done in the end of 23, and there were 1.5 million women in the UK.
Wow.
And 200 million globally.
Wow.
It's a lot.
Yeah. That is a lot. Awesome. Yeah. Tanya, thank you so much for today. I can't think of anyone. So I can't remember what number episode this is going to be, maybe 176, somewhere around there. And I can't remember someone answering questions so thoroughly.
Oh, wow. That's a praise indeed. Thank you.
Yeah, it's just really, really great. But what's next for you? What have you got in the pipeline?
Oh, thank you. Well, if you don't mind, hopefully this will air before that, but I am running a practitioner masterclass in East Sussex on the 15th of October, all on mapping endometriosis. So I do one of these a year, and I haven't covered endometriosis for 2 years, and there is a lot of new learning that I am on the edge of my seat to deliver. So for anybody that this has sparked your interest, please do look on my website under events, and you can book your ticket. And hopefully you will enjoy the way that I run my masterclasses. I practice what I preach. I run these in a beautiful spot in East Sussex in a field, and it is a day of immense learning, but also connecting with colleagues and clinical pearls, but also looking after yourself. So we do yoga and we do breath work, and you're fed beautifully and watered beautifully. So hopefully that will spark some interest. But I'm always, I'm head of education from Rita, so I'm always on a webinar somewhere. And I also run a mentorship group annually as well, all around women's health. So that will start again next January. So if you like to work with me, then there's always a way to work with me. But I'm not currently seeing clients, sadly, but if you can contact me and I can refer to people who've gone through my mentoring program, and point you in the right direction of some amazing practitioners.
Awesome. And what's the best way for people to get in contact with you?
So if you go onto my website, tanyaborowski.com, www.tanyaborowski.com, you can see all the contact details of how to work with me or come to any of my teaching there.
Awesome. And I'll make sure those details are in the show notes.
That would be great. Thank you.
Tanya, thank you so much again for today and sharing your knowledge.
Fantastic. I'd definitely love to talk to you more. So thank you so much.
My pleasure. And I'm sure the audience are going to love this episode as well.
Great. See you soon.
So that's it from Tanya and me for this week. But be sure to tune in, same time, same place next week on Beyond the Pain. Thanks for listening to Beyond the Pain. If this episode resonated, please follow the show, leave a review, or share it with someone you know who's been struggling. And remember, pain is not permanent. With the right insights and support, you can turn it into power. Until next time, stay open, stay strong, and keep moving beyond the pain.